This video reviews the contact lens software in your Medmont E300 corneal topographer on diseased and post-surgical eyes. Start by evaluating your initial best topography. In this case, even on this keratoconic patient, we see a good area of coverage, but yet a lot of missing cornea toward the periphery, given that this is a fairly large visible iris diameter patient. A good reminder of using the composite eye, taking a central image, having the patient look nasal, take another image, having the patient look temporal, another image, having the patient look up, pushing the placido to the inferior cornea, having the patient look down, pushing the placido to the superior cornea. Merging all those together, we get a much larger view of the eye, better for constructing rigid contact lenses from. Next, let's go up to Home and Contact Lens. Then we can select from the design list a keratoconic specific design. Then click OK. Next, center the contact lens to where you think it appears geometrically centered to the visible iris. In other words, does it look centered as if you were looking at it through the slit lamp, looking at the white of the eye in relationship with the contact lens diameter. Next, choose parameters that are in your diagnostic set for this particular specialty lens. Then click your cursor in the center. Measure the apical clearance. We're at 46 microns. In a normal eye, we ideally want 20 microns of fluid at the apex. In a diseased eye, a little bit more, maybe 30 microns, in order to protect the cone, in order to be sure that we're clearing the diseased area of the eye. At 46 microns, we're a little bit steep. We generally start to lose VA in a corneal GP lens when the fluid layer is beyond 40 microns at the center. Let's flatten the base curve, a couple clicks, and apply. That takes us down to our target of approximately 30 microns. Now we can grab the little handle on the end, rotate it around, and find the axis of greatest bearing. And it appears that this lens lands at 3 and 9 o'clock. We'd get good lateral stability from that relationship. So let's take the axis line to the opposing meridian. And we see the lens very close to the cone, if not touching. Clicking our cursor in the center, 6 microns over the cone here, 4 microns there, very little. Let's steepen the base curve up to make sure that this lens does in fact clear the cone. Now, steepening the base curve may allow for better clearance over the cone, but of course that may result in us clearing just superior of the apex, having too much fluid. Right now it's 62 microns, a bubble's created at 90. If we steepen it up a little bit more to ensure clearance over the cone, we're in the neighborhood of almost 80 microns of fluid. So it's important to find that happy medium between clearing and protecting the diseased area of the eye while not having excessive fluid within the pupillary zone that could cause a reduction in VA. Let's flatten the base curve one step, and that gives us 70 microns of fluid in the superior pupillary zone, whereas over the cone about 15 microns. This lens appears to be a good starting point. We've got a landing at 3 and 9 o'clock that would create good lateral stability. We clear the corneal apex by about 55 microns. We might expect a little wishy-washy visual acuity since we have so much fluid. We've got 70 microns heading north over the cone, 15 microns heading south, 88 microns. We're staying just below that threshold of 90 microns where bubbles can form. If this lens cannot create a decent lens to cornea relationship due to the asymmetry of the eye, then we know that it's most likely we need a piggyback system, having a plus lens underneath to fill in this space here and protect the cone, or possibly a scleral lens. If we're happy with the construction of this lens, we'll put on that diagnostic, or if we want to take a chance on the initial fit of this lens, we could custom order based on the parameters down here and the calculated lens power.